Hi everyone, so this is going to be either my last or second to last video. I think I might at the very end of this do a total how to do well on your psychiatric rotation video. Just some general tips and tricks that I learned about doing rotations in psychiatry or any rotations in general, but this one in particular is going to talk about creating a formulation, assessment, and plan given the data that we've gathered from the prior two videos, and how do we now, with that information, create assessment and plan for this patient and person that we're seeing. I won't get too much into how to write notes. Every place does it differently, and every preceptor is going to require something different. That really is something you're going to have to adapt to depending on preceptor and what they want. But just for your own knowledge and uh, clinical skills, I think it's going to be helpful and something that I'm still working on to this day. How do I take the information I gathered and really make a uh, treatment plan based off of what I'm seeing? So I think there's going to be 2 to 3 different things that I'm going to use, and I have a bunch of notes written down right here for some guidance because I haven't written or looked at any of these formulations in quite some time since my last psychiatry rotation, excuse me. But I'm gonna have kind of the basic outline of what most people in a rotation might be looking for, and then each next step is gonna have a little bit more detail than the next, and that hopefully that should cover you for any rotation. And it's also going to include that one-liner that we should have when we're presenting a patient, which is also going to go in our assessment and plan. So that's kind of what this video is about, and hopefully is not going to run too long like the previous first one at least. And yeah, so let's get started. Okay guys, should be recording right now. So let's get started with the formulation assessment and plan. Taking the history we had from the previous patient, um, I created a one-liner for us. And why don't we start there? So our one-liner is going to be something that encompasses a good idea that we can present with our attending or put in our note that is going to give us a clear understanding on what is going on with the patient. Um, so it should include identifiers and demographics, who the person is, race, ethnicity, um, if they're unhoused, things like that can really matter. Past psychiatric history and pertinent past medical history. So past psychiatric history is going to be important, as we know, but past medical history, like did they have a traumatic brain injury? Have they ever had seizures? Things like that could affect medication management. Is really good pertinent stuff to put in there. Reasons for visit, what brought them in today and how were they brought in? So were they brought in for suicidal ideation, suicidal attempt, self-injurious behaviors? Were they brought in voluntarily? Were they brought in from the police? Where were they found? Things like that. And then referral, again, who were they brought in by? Was it from an outpatient psychiatrist or therapist? Was it from someone in the community? Um, Triggers and stressors, what were the things that are the biopsychosocial things that could possibly causing the current admission? And relevant labs and UTalks, especially important for consultation liaison psychiatry or ED psychiatry. But are they coming in with um, substance use or substance positive on their urine tox screening that can be causing the mood symptoms, or any relevant labs that can be causing the mood symptoms. So based off of what our information was from the patient that we were seeing, might not have all the information. I didn't look back on that video too much, but just from what I remember, I created a sample of what could be our one-liner that we either present to a patient, or I'm sorry, present to attending, or that we write down in our assessment and plan. I haven't done this in a while, so please take everything with a grain of salt, but it could give you just an idea. And then while you're on your rotations, you can continue to refine it based off of what the attending desires. So, for example, for this patient, John Doe Smith, 57-year-old Caucasian male with past psychiatric history of depression, suicide attempts by hanging, In 2010, 2012, and 2020, voluntary brought in by ambulance presenting today with suicidal ideations with plan and intent. I can also include how. I think you said it via uh, via drinking and gunshot. And self-injurious behaviors of vertical accelerations bilaterally. UTOX negative, but blood alcohol level was X. Um, that is our one-liner. It gives an idea of why the patient is being brought in, how they're being brought in, and the severity of. I think we're back. Okay. The next thing is formulating, I think we can do next is formulating the biopsychosocial history. So a lot of attendings like when you do this, a lot of people say don't no need to include it. Again, it's attending dependent, but for our sake and purposes, based on this patient, it kind of helps figuring out what we want to do based off the history of what we're seeing. So for example, this patient has family history, biological family history of anxiety and depression. Those things are, there's some genetic component in um, psychiatric illnesses, so that's important to include. Psychological history of trauma and social history of marital status issues like divorce and work environment issues, like stressful jobs. These things can be affecting the patient, and depending on what that biopsychosocial formulation looks like, can change or make us think about different things that we need to do for the patient. So, for example, if this is the patient's first time coming in with any self-injurious behaviors impulsively, that might look different and doesn't have any of the biological or psychosocial issues, and maybe some social issues like, I don't know, bullying, for example, or some work issues that might present differently than someone who has this history um, of issues along with their past psychiatric history, and depending on what their insight looks like. So it's something that we can add to our assessment and plan to further support why we're choosing to discharge a patient, why we're choosing to put them on a hold, or why we're choosing to prescribe certain medications. And we'll get more to that in the bottom with the example that I have here. All right, so things to include in general in our assessment and plan. These are the things that I found must needs that will create a good foundation or skeleton for your assessment and plan. First thing is how the patient is presenting. Um, are they dysphoric? Are they mood congruent? Are they mood incongruent? Are they disheveled? Are they delirious? Things like that. How is the patient presenting today? Are we um, and then here how the patient's presenting, it's good to put in some of those MSC findings, right? So whatever we found on our MSC is something that we can include there as well. Any diagnostic changes or medication changes or anything that we'd like to add or anything um, that we need to change basically, right? So if this is a follow-up and we're understanding the patient's history a little bit more, we can do diagnostic changes. If this is the first time, we include the diagnosis there and we can include what medications we want. Again, what do we want to do? Do we want to include any medications? Do we want to discharge the patient? And then again, reason for staying discharged. What are we doing with the patient? Are they going on a hold? Are they being discharged? Why or why not do they need to be here? Some of these things, they're going to be templates at your rotation or specific wording uh, that's required by the hospital that, a resident, a fellow, or an attending might provide. Um, so I wrote a very quick and dirty assessment and plan for you guys to kind of look at based off the patient presentation we had at the beginning. Again, I have not written one in a while, so it might not include everything, but this is kind of the skeleton that you can start out with. Maybe have for your records, and then as you continue on your rotation, refine it to sound like you, to make it your own X, Y, and Z. So this is the beginning that we included in um, our one-liner. So we'll start from here. So upon evaluation, patient presents today dysphoric with fair insight and good judgment to his mental illness. The patient minimizes his need for stay. So that kind of tells us how well the patient knows their reason for hospitalization and mental illness. Given the patient's current mood systems and the current working diagnosis is major depressive disorder severe. I'll get into this a little bit more. Um, Again, I've heard people include all the social history, all the legal history, all the substance history, all that stuff that we included from the intake that was in the HPI. People include here. Some people just say, "I got the information. Tell me why we're coming to this diagnosis quickly here." So that's again dependent on attending and what they feel like. You can expand more on why the current mood systems are occurring and what they are by talking about the SIGI caps and how much of the criteria um, they check off. I don't know why it's doing thumbs ups, but good job. Okay. um, and then this is where we can include some of that biopsychosocial if the attending wants it. Oh, let's see, it goes up to here, I think. Okay. So, patient's affect stems from recent social stressors such as divorce and work, and ongoing biological stressors and psychological stressors such as family history of depression and trauma. Again, you can go into what type of trauma, what medications that the family was on as well. Um, and then we go on to what we want to do, right? So, patient would benefit from starting Zoloft 50 milligrams POQD for depression. Um, this, we can also even go into more of why do we choose this medication? Well, the patient was, I believe we chose this medication last time. Well, the patient was on this medication prior and had good efficacy on the medication, so we want to start there. Some backup medications could be Lexapro based on family efficacy on that on Lexapro medication. I think because the patient was drinking 2 liters of alcohol, it includes CWAP protocol. And what are we doing with the patient? Are they staying or are they leaving? So, given patients' need for continued medication management, recent suicidal ideations with plan and attempt, um, suicidal self-injury behaviors, patient needs high acuity inpatient care on a 5150 hold for DTS. So this line really is often copy and paste from um, the hospital what exactly needs to be said to make sure that they're placed on a hold and what needs to be included. This is again skeleton, but this is a good example of, you know, what do we want to do with the patient and why. Uh, Patient will be monitored for side effects on the medications, will be adjusted accordingly. Patient requires inpatient hospitalization for further safety, diagnosis, reduction of symptoms, and ensuring a safe discharge plan, which we'll continue to follow up later. So that is kind of the assessment, formulation, and plan. Now, this might look different if this is the first time a patient has ever been in due to passive suicidal ideations, right? Do we choose to discharge that patient then? Um, do we choose to discharge a patient because of good insight and impulse control issues, right? That's where the nuance comes from. But if you have a good plan, if you have a good history taking, sorry, if you have a good history taking, if you have a good objective findings, and it's backed up all the way through and included in your assessment and plan, uh, I think you're in a fair spot. And even if you're wrong, even if the attending decides to do something different, at least you gave a good understanding of why you wanted to do what you wanted to do, and you'll be way above and beyond for what maybe a third-year medical student would do, or even maybe a fourth-year medical student. Um, so I hope this was helpful. I hope that uh, there was something in here that you can take away. And this is how to uh, create those one-liners and create a formulation methodically and how to possibly document it in our assessment.